The first important specimen is that of peptic ulcer. So peptic ulcer, it is commonly seen in the stomach and duodenum, first part. So how do we describe this specimen? So this is a gastrectomy specimen. We can identify the stomach by these gastric rugae, and it is showing a round to oval shaped ulcer which is sharply punched out defect in the gastric mucosa, and the margins are seen overhanging the base. Now here again there is another ulcer in the gastric mucosa. It is round in shape, and in this specimen again this is a gastrectomy specimen which is showing a oval shaped ulcer. And an important observation is that these gastric rugae, they are seen converging in the center towards the margin of the ulcer. So this is an important clue to diagnose a peptic ulcer, because in peptic ulcer the gastric rugae, they are radiating, they are seen converging to the margin of the ulcer. Now base may show some granulation tissue. So this is how we describe a specimen of a gastric ulcer or peptic ulcer. Now next important specimen is ulcer in a case of gastric carcinoma. So again this is a gastrectomy specimen, and we can identify this by the rugae. So the examiner can ask you, how did you make out that it is a specimen of stomach? So we identified it by the presence of these rugae. Now this is a specimen showing irregular ulcer with heaped up margins, or we can also call that rolled out margins. So we can see there are thickened margins, so rolled out margins. And the important point is that the gastric folds, they are not radiating like they were radiating in case of peptic ulcer. So these are non-radiating gastric rugae, and because of this we can make a provisional diagnosis that it is an ulcer in case of gastric carcinoma. Now when you diagnose this ulcer as gastric carcinoma, the examiner can ask you what are the different types of gastric cancers grossly. So grossly, how do the gastric cancers appear? So the answer is that they can be seen in the form of a nodular growth like this with the ulcerated center, or secondly they can be seen in an infiltrative pattern where the cancer cells, they are infiltrating the wall of the stomach and they are leading to the thickened wall of the stomach, but there is no visible nodular growth. So these two kinds of growth can be seen in case of gastric carcinoma. One is nodular with a central ulceration, and second is infiltrative where the wall of the gastric cancer, the stomach is diffusely thickened. And the next question comes, what is a leather bottle stomach? So when there is infiltrative pattern of gastric cancer, then what happens, the wall of the gastric or wall of the stomach, it gets infiltrated by the tumor cells, and there is intense fibrosis in the wall or desmoplasia. So that leads to a stiffened wall of the stomach, and it gets the name leather bottle stomach or linitus plastica. So this is again an important viva question. Now next important viva question is, what is a Virchow's node? So when there is metastasis of gastric carcinoma in the left supraclavicular lymph node, it is known as the Virchow's node. Next important question is, what is Sister Joseph Mary node? So when the gastric carcinoma metastasizes to periumbilical lymph nodes, then that lymph node is known as Sister Joseph Mary lymph node. Next, Krukenberg's tumor. So when the gastric carcinoma metastasizes to the ovary, and commonly it affects the ovary bilaterally. So in that case it is known as Krukenberg's tumor. Then another question is, what are the various ulcers of the gastrointestinal tract? So you know that gastrointestinal tract extends from the oral cavity till the anus. So various ulcers which can be seen throughout the GIT can be aphthous ulcer. Then in the esophagus we can say that herpes simplex virus esophagitis leads to ulcer. Then in the stomach, peptic ulcer, ulcer due to gastric carcinoma. Then in the intestines we can say Crohn's disease, ulcerative colitis, typhoid ulcer, tubercular ulcer. So these are the ulcers which can be seen in GIT. Now next, this is what I was talking about, linitis plastica or leather bottle stomach. So it is another important viva question. Here the tumor cells, they infiltrate the wall of the stomach. This is a gastrectomy specimen and you can see the wall is so much thickened and there are loss of the rugae. Here the wall has increased desmoplasia or fibrosis, so it becomes very stiff like a leather bottle. So it is known as leather bottle stomach. Important viva question is, how do you differentiate between an ulcer which is from a benign cause like peptic ulcer and if it is because of gastric carcinoma, that is malignant ulcer. So clinically there can be many differences, like the peptic ulcer will occur at a younger age group and it will be seen in the lesser curvature. The malignant ulcer will be seen in an older age group and commonly seen in the antrum, also the lesser curvature, but we are concerned with the gross features. So the size of a peptic ulcer will be smaller in size while malignant ulcer will be larger in size. Now the benign ulcer will be regular in shape while malignant ulcer will be irregular in shape, and very important point is the edges of the benign ulcer will be sharp and punched out. It seems like the tissue has been punched out from the mucosa, while in malignant ulcer the edges are rolled out, like they are heaped up at the margins. Next important differentiating point, which I already told you, is that gastric rugae, they are radiating and they are seen converging towards the margin of the ulcer, while the gastric rugae, they are arranged randomly in case of malignant ulcer. So additional difference is when we investigate the patient, then in the barium studies they will be punched out ulcers seen in case of benign ulcer, while in case of malignant ulcer there will be irregular filling defects. So these differences are important, especially the gross features. Now again this image, so that you understand better how to differentiate between the benign and malignant ulcer. So in the left there is benign ulcer and in the right is a malignant ulcer. So you see the different gross appearances. In this you have a sharp punched out defect in the mucosa with the gastric rugae converging towards the margin of this ulcer. Now in this we can see these are larger in size, irregular, and the gastric rugae, they are non-radiating. In the base we can see some necrotic slough also. So this is a malignant ulcer, and a very important point is the heaped up margins. So we can see these margins, they are like rolled up or heaped up margins. So it is important finding in case of a malignant ulcer. So these were all the important points in case